Hello and welcome to our webinar, which is titled Endometriosis, Menopause and Nutritional Considerations, Understanding the Journey and Advancing Diagnosis. My name is Paul. I'm from White Research, which is the partner leading the dissemination and communication activities in the Sensopad project, and I'm very happy to guide you through today's discussion. And this marks the first webinar in a series of webinar series and different awareness raising activities of Sensopad, where each time we will explore different aspects of endometriosis and related women's health topics. And endometriosis is a chronic disease that affects millions worldwide. Its journey spans a woman's reproductive years, often for many years, and for some, it continues to present challenges into the menopausal transition. And understanding the hormonal shifts and the powerful role of nutrition and lifestyle in managing this condition is paramount. But I will not explain this in more detail because we have different experts today with us that will explain about endometriosis, but also the role of Sensopad project in helping with diagnosis. And before we dive into the specifics of endometriosis management and an overview of the condition, we must acknowledge also a critical challenge in the endometriosis community, and that's the significant diagnostic gap, where the average delay to receive a diagnosis is approximately 7.5 years, and where early non-invasive diagnosis is key to timely management and improving quality of life. So today we're honored to feature a brief overview of an ongoing research effort aiming to address this very issue. That's the Sensopad project. So now I would like to introduce our speaker from the Sensopad team from the National Technical University of Athens, NTUA, and that will be Stelios, who will provide an overview of the current diagnostic challenges and how the Sensopad project aims to utilize innovative, non-invasive technology to advance the way we diagnose endometriosis. So Stelios, please, the floor is yours.
So thank you very much for this. I will now proceed with the presentation. Okay, and then this one. Okay. All right, so we're Sensopad, and in Sensopad we are fighting endometriosis. So what is endometriosis? Well, it comes from the word endo, which in Greek means inside, meter, which comes from the Greek word for uterus, and eosis, which is a suffix for a medical condition. So all in all, endometriosis is a medical condition inflicting women where parts of their uterus is being set into the peritoneal cavity. How many women? Well, in total, we have 190 million women globally. But what is endometriosis? It's pain. Pain at work, pain when using the toilet, pain during intercourse. And it's a debilitating pain that can result to hysterectomy. Now, what we know so far is that there are some products out there that are very good for self-monitoring, and there are fewer products that can be characterized as a biological processing unit. And so what we wanted in Sensopad to do is to build a device that will enable self-monitoring, but at the same time will give us all the output that is normally expected from a molecular biology lab. So we're building a pad, a layer specifically, that is going to be a point of care device. It's going to receive menses, and it's going to give indications for inflammatory proteins, and it's going to be energetically autonomous. How does it work under the hood? Menses falls on the pad. Bad inflammatory proteins bind to what we call plastic antibodies. And when the binding happens, it gives two outputs. One is a change in the color of the pad, and the second is an electric charge that is then transferred wirelessly to a cell phone. But Sensopad is not only about women. It's also about clinicians who want to really understand and correlate what we call mutations at the level of DNA with endometriosis. And in here, what we would call the direct and indirect competitors would be, for example, a physical examination, which is cost effective, but it's not very informative. And on the other side, we have sequencing devices and clinical monitoring. So what we want to do is to build a device that combines both attributes. So what are we building as well? This is called the Senso microfluidic graphene field effect transistor. And it is able to read the DNA coming from menses of women and give us correlations between what we call single nucleotide polymorphisms and the phenomenon of endometriosis. The benchtop device is also going to be fully automated. So how does it work? Menses goes inside a microfluidic device. Then the device isolates cells. Then the genomic DNA from these cells has been removed. Then it goes again into the device, and finally it goes to the graphene field effect transistor that automatically detects SNPs. Finally, the SNPs are read via the internet by clinicians, who then can correlate the SNPs with endometriosis. So this is our roadmap. We began in 2024. We have been designing and building the main elements of the device. We plan to start prototyping in 2026, where we're going to integrate and calibrate the prototype. Moving on in 2027 in pilot trials and biomarker validation, and hopefully launching by 2028. So let's end the silence. Let's deliver accessible diagnostics for endometriosis. Join us in empowering millions of women worldwide. And that's it. That's the Sensopad Consortium, two fascinating products from a stellar consortium.
Thank you very much, Stelios and NTUA, the coordinator of the Sensopad project, for this very clear and interesting presentation on the critical work that's being done already as part of this project, and which will help us move toward earlier, more effective and less invasive diagnosis. But now, as a main presentation for today, we transition to the core topic of our webinar, which is a deeper dive into managing endometriosis through menopausal changes and the power of nutritional and lifestyle choices. And for that, I am happy to introduce our main speaker, Dr. Amanda Stuart. And Dr. Stuart is an expert in pelvic health care, bringing a comprehensive approach that integrates hormonal health, pelvic floor physical therapy, and lifestyle support. So Dr. Stuart, welcome, and we look forward to your insights.
Thank you so much for having me. I am so excited to talk about this. I will get going here to share the presentation. Okay, so as it was so nicely introduced, I'm going to speak today about endometriosis through menopause, and then some overall nutritional considerations to help alleviate some of the symptoms here. So the first is just a general overview of what is endometriosis. It is a chronic disease. It is not considered autoimmune, though it does tend to act a bit like an autoimmune disease. Often what you'll see, and I put this little photo here, and we'll have a few more photos throughout, where the parts here of the or estrogen-like tissue is growing outside of the endometrium. So we'll see here that there are these lesions that are these dark red splotches in the photo here, and that is what we characterize as endometriosis, and it's growing in areas that it shouldn't be growing in. Although lesions have been found in many areas, the most common is the pelvis, and this is why it is so imperative here to discuss the pelvic floor and how this affects pelvic floor function. And lastly here, as we'll touch upon menopause in a few slides, because of the estrogen-dependent nature of the disease, menopause transition usually alleviates or eliminates symptoms of endometriosis, making it mostly a premenopausal condition. And we'll talk a bit more about what that means and the different symptoms we may experience going through menopause here. Now, as far as the clinical presentation, endometriosis usually becomes apparent in the reproductive years when the lesions are stimulated by ovarian hormones. Symptoms tend to be strongest premenstrually, and they subside after cessation of menses. So what that really means is most often women will say about 3 to 5 days prior to their period, their pain will be exacerbated, and that could be low back pain, pelvic pain, abdominal cramping. And then the first few days of the actual period tend to be very painful as well. And then once we're at the end of menses or it's stopped, it'll be relatively better from there. So that's another clinical sign. Normally, these women, when you ask them how their menstruation is, it's quite apparent that they're either missing school or work or they're staying in bed around their period time. And that's one of the biggest indicators of endometriosis, is this severe pain surrounding menstruation, which we call dysmenorrhea. Pelvic pain being the most common presenting symptom. So as I just talked about during menstruation, however, it is common that pain is quite consistent and unprovoked in the abdominal region, the low back, and within the pelvis. Additionally, most women will have what I call dyspareunia, meaning pain with intercourse. That pain typically is deep and infiltrating when it's related to endometriosis. I always ask women if it's more of a insertional pain or a deeper pain, because that's going to tell me two different things. But the very pertaining to endometriosis pain will be the deeper pain during intercourse. And then there can also be pain present during bowel movements or urination. This next bullet point here just speaks to a survey with beyond 70% of women tested in the United States and in the UK, showing how prevalent pain was when they actually had endometriosis. And often women will initially just get diagnosed with irritable bowel syndrome, because when they're talking about abdominal pain and discomfort, and clinicians aren't as familiar with endometriosis, they'll just give the umbrella term of irritable bowel. Okay, medical treatment here. So typically, because these women are so young and this diagnosis is largely overlooked, there's going to be a series of medication that's given to them first to try to alleviate symptoms. What that may look like, so of course, our NSAIDs are very common anti-inflammatory drugs. Often and most widely used would be oral contraceptives, so birth control pills. I see this less frequently, but there can also be given progestins or androgenic agents, so a gonadotropin releasing hormone that's stopping a large amount of these reproductive hormones from producing at all. Because that is a bit stronger, I don't see that very often, that women are put, at least as a first defense, on a gonadotropin releasing hormone. I'll talk a bit here about OCPs or IUDs, because that's what I see the most common. And I did put just a little graphic here of the typical stages of how clinicians will go through treating, most often before a diagnosis of endometriosis is given. The oral contraceptive pill, because it actually stops the ovaries from producing estrogen and progesterone, and it provides a synthetic hormone that often will alleviate to an extent the symptoms of endometriosis. An IUD, I personally feel is a bit preferable over an OCP, just because the IUD doesn't stop the ovaries from producing and functioning as they should. It just modulates the hormonal production. Neither of these medical treatments, though, are addressing the root cause, right? So ultimately, the gold standard of treatment would be excision surgery. And so that would be going in. Typically, it's going in through the abdomen. There'll be a couple short incision points, and they'll actually remove the endometriotic lesions there. And that is the best and most efficient way in dealing with endometriosis, because you're actually removing the lesions there rather than just giving a medical treatment to mask the symptoms. The caveat with the excision surgery, it is the gold standard, but recurrence can be common. And this is where getting into or working with a practitioner who's familiar with endometriosis is helpful. In order to lessen the risk of recurrence, nutritional and lifestyle factors, largely targeting what I would call foods and products that are not phytoestrogen. So basically, because this disease is so built on an overproduction of estrogen or estrogen-like hormone here, you want to try to avoid any toxic products that you're putting on your body, any chemicals that you may be using at home, say to like clean your house, for example, and then largely just foods that will not have a likelihood of increasing too much inflammation or helping to facilitate more estrogen in the body. Sometimes a surgeon will recommend going back on an OCP or an IUD just to help mitigate too much estrogen from circulating through the body again and causing the recurrence at a faster rate. I think in that situation, it's very dependent on the woman, because some women don't want to be on birth control or forever either. So it's just good to have some lifestyle factors to fall back on. Ultimately, as well, pending the age of the female, they could always decide to get a hysterectomy. So just remove where the lesions are coming from, so the ovaries, etc. Here, so right before I go into the overview of menopause, one of our newest right now in the United States, what we've been talking about is testing the blood, which kind of goes in nicely here with Sensopad's movement on testing AMH, anti-Müllerian hormone, in these young women who are talking about very significant period pain. And that just means, so our anti-Müllerian hormone tells us our egg reserve. So this is also where it comes into a bit of fertility. So the lower your AMH levels, that's indicative that there are less eggs. Now, when a woman is really young, she should have a lot of eggs. So we're now seeing this shift, or a lot of gynecologists and specialists in the field with endometriosis are talking about testing women for their AMH at young ages to help determine, without doing excision, their likelihood of having endometriosis. So that's really new, really exciting as well. Here is an overview of menopause. So briefly here, it's technically defined as 12 consecutive months without a menstrual cycle. On average, this occurs in the early 50s. Now, it's a decline basically in the ovaries, and that basically means is that there's a large, very, very large decline in estrogen and progesterone, because ultimately the ovaries have mostly at this point stopped producing. A decline in estrogen and progesterone lead to complications, so blood sugar dysregulation, cardiovascular risk. So there's a lot of talk about heart health when these hormones are significantly declined here, gaining weight, and a decline in bone health. Now, menopause symptoms. So again, in this slide, I won't go through each one, but I think some of the biggest ones, especially pertaining to this presentation. So the vasomotor effects, hot flashes, night sweats, cognitive issues, so forgetting things more, feeling a bit more brain fog, the greater risk of cardiovascular disease. Now I'm going to just go down here to the genitourinary syndrome of menopause. So basically, what we see often is with the reduction of estrogen and progesterone, many women will start to get pain with intercourse, now talking more superficially. And this tells me that the tissue is just, it's more thin, it's raw, it's often discolored. And women will talk about, they'll feel the raw paper like feeling of the tissues. They'll also talk about urinary, so urgency, that's quite significant. They'll always be almost feeling their bladder, and frequency of urination. Now, I'll touch upon treatment for GSM when we get to a bit more of the pelvic floor treatment. Sticking through menopause here. So menopause with endometriosis. So typically, menopause is helpful for women with endometriosis if they still have their uterus, their ovaries, etc. Now, this is because that decline in estrogen is very favorable for decreasing any recurrence of endometriosis. I think the bigger question here when we're talking about menopause with endo, most times we're going to see that it's favorable. So a huge reduction in symptoms. We're not worried about recurrence of endometriosis. However, they may still feel GSM, they may still get hot flashes, they still may get the symptoms of menopause. And this is where I think we're trying to decide, well, would you still put them on a hormone replacement therapy? Because now giving them back estrogen and progesterone, what does that do to lesion growth? So here, what we're finding, of course, it is very individualized and dependent on a woman's symptoms. So if she goes through menopause and she had endometriosis and she feels great, then awesome. Like, this is a great scenario. Now, if a woman has endometriosis, she goes through menopause, but is having, whether it's genitourinary symptoms or the hot flashes, night sweats, etc., or cognitive issues, the research is favorable to still put them on a hormone replacement therapy, starting at low dose and monitoring consistently. The caveats being here, you wouldn't give these women estrogen only hormone replacement. So you would look for a combo of estrogen and progesterone. So of course, the progesterone will balance the estrogen and prevent it from rising too high. Or what was actually interesting to me was also this tibolone. So we don't have that in the United States, but I had read that it's often recommended in Europe. So everyone listening to this probably knows a bit more about it than me, but it does seem that it is a synthetic steroid used as an alternative, and it has estrogenic, progesterone, and androgenic activity. So you're actually getting all three hormones in a synthetic, safer version in one treatment here. So basically, long story condensed here, you're looking to either balance estrogen or go with a treatment similar to this Tibolone, which will have all three, and it's not so estrogen dependent. The other last thing that I want to mention before I go to the next slide is that vaginal estrogen, we talk a lot about it here. So a vaginal estradiol or a vaginal estradiol with testosterone compound cream that a woman would just place on the vestibule tissue, that would address the genitourinary syndrome of menopause. And because that is local, there is absolutely no risk for women with endometriosis. So as a first line of defense for women experiencing any intercourse pain, any urinary or bowel dysfunction, I almost always recommend that they see a practitioner for vaginal estrogen. Again, that's localized. It does not circulate through the bloodstream, so there is no risk. Only benefits can be seen through taking that. And the clinical takeaway here, it just summarizes all of what I had just talked about. So treating each patient as an individual, what are her symptoms when you're thinking about addressing hormone replacement therapy, and then coordinating with a specialist who can help you with these different parts. Now, I'm just going to go in here to the nutrition and lifestyle support. So we're going to talk about 4 things here. So anti-inflammatory foundation, key micronutrients and compounds, dietary patterns, and food and or factors to limit or avoid. So this is your very holistic approach here, and this is something that I love talking about. So here you'll see anti-inflammatory foods. So antioxidants are key. There have been a couple different studies here showing that a larger intake of antioxidants, which are going to come from your fruit and your vegetables, they had a 30 to 40% reduction in endometriosis symptoms alone. The additional here, so fiber. Fiber is a huge emphasis in the diet as well, because it's going to just help the gut clear things out. And whenever we clear things out, we're also going to be clearing out excessive estrogen. So that's a win here. Omega-3 fatty acids, so the best source being fish. And some of the smaller sources would be a chia seed, flaxseed, walnut. Olive oil is a great other anti-inflammatory food here. Key micronutrients. So vitamin D is a huge one because of its overall health on, or overall help on immune system health here. Normally, I'll recommend a liposomal vitamin D supplement to be taken. Magnesium and zinc. Magnesium is huge for just abdominal cramping, down regulating the nervous system. It's a great supplement, and largely people are deficient in it anyways, so it's a good thing to take. Some of the more specific micronutrients here, so resveratrol, quercetin, and curcumin. And then I had already spoken here about the importance of fiber with a recommendation of 25 to 30 grams a day. Pro-inflammatory foods to limit. This I feel is quite, we've heard this before. So any processed meats, any red meat in particular, though I do think that if it is grass-fed meat, that is a bit better, but in general here, so processed meats, red meat, high fat, dairy, non-organic dairy can raise estrogen levels. Any trans fat in seed oils are very inflammatory. So we're trying to avoid inflammation to keep lesion growth at bay, to keep it from not getting irritated. High caffeine and alcohol intake. And then, of course, any ultra processed or refined sugars. So basically, you want to stick to something whole foods, minimal ingredients when adopting a diet here. The only other thing to make note of is just this is where the environment comes in, and there's only so much that we can control with environmental, but overall, they're kind of cookware and lotion, perfume, soap, all of these things, there are just great substitutes that don't contain BPAs or microplastics or estrogen causing compounds. So it is well worthwhile to look into. There's actually a great app that people can download on their phone, EWG, and it will actually rate products for you so that you just have an idea of what's better for you. Clinical takeaway here, the recommendation across multiple articles, studies, etc., is the Mediterranean diet. So that encompasses pretty much everything that I just talked about in the previous slide. Now, effects on the pelvic floor. So premenopausal women who have endometriosis, they tend to experience pelvic floor issues related to tightness because the endo lesions are so close to the musculature. The muscles will guard in response. So this is the clinical symptoms that we were talking about a bit earlier. So that would be pain during menstruation, pain with deeper intercourse, low back and or abdominal pain, and urinary frequency, urgency, a lot of gut discomfort, and they can also have pain during bowel movements. Postmenopausal women, as we talked about here, will either get relief from the severe reduction in estrogen, or they could demonstrate some of those urogenital symptoms. And that's where both pelvic floor to address releasing the tension in those muscles and a vaginal estrogen go hand in hand in treating GSM symptoms. And because pelvic floor therapy, similar to a protocol for women with endometriosis, it's highly individualized. So this is a big summary here, but it just shows you're looking not at strengthening the pelvic floor or doing a lot of Kegel exercises. You're actually looking at the opposite. So you want to downregulate the nervous system through diaphragmatic breathing, stress reduction, working on stretches to open the pelvic floor here. Any surrounding, so abdominal, low back, the upper thighs, working on any connective tissue or fascia that has also tightened in response to the lesions and the tightness being present for so long. And then just an aside, in some cases, and most often, a female with endometriosis is not just seeing a pelvic floor physical therapist. It's typically a team. So we'll have a gynecologist, a pain management specialist, a surgeon on board. And that's when there also may be outreach. So neuromodulating medications, hormone replacement therapy, topical hormones, pelvic floor muscle Botox, like it kind of can grow from there. And that just highlights the importance of finding a specialist that does this often and is very familiar with how to treat endometriosis. I will breeze through this patient case here. This was a patient of mine, though. She was is 32. was presenting with dysmenorrhea. It took 10 plus years for her to be diagnosed. So she was put on a gonadotropin releasing hormone years ago, and that helped alleviate some of her symptoms. But she largely had to give up like her exercise, foods, lots of food, spicy food, any kind of alcohol, gluten, anything fried, really exacerbated abdominal pain. She had a lot of low back pain. And she just about 6 months ago got the surgery. I had recommended that she see a surgeon around here, and it was successful. They removed it. She had lesions kind of spread throughout between the ovaries, the pelvic floor, etc. Anywho, now currently I'm still seeing her. The endometriosis has been removed, and she did decide to go on an IUD following the endometriosis excision surgery. But her success has been lovely. She's had, I'd say at this point, about 6 months out, she's had an 80% reduction in unprovoked abdominal and pelvic floor pain. She does not have frequency or urgency of urination anymore. She's not waking up at night to urinate anymore. She does not have pain during menstruation. She'll have some abdominal discomfort on the first or second day of her period, but it's quite minimal. She has, at this point, when I typed this, I put nearly pain-free intercourse. At this point, it is pain-free, which is really exciting because that was about a 2-week span of things continuing to get better. And her ability to eat food is so much larger now. She'll still stay away from fried and spicy foods. But this is a typical trajectory that we expect to see, and I anticipate that she'll get better throughout. A couple of the references here, and then lastly, I know I just threw out so much information, and I apologize about all of it. As you can see, I'm really passionate about this topic. So if there is anything that we don't get to address today, please do feel free. I left my information here with my email, and I'm happy to answer any questions. So once again, thank you so much for having me, and I hope that this was digestible here.
Yes, thank you. Thank you very much, Dr. Stuart. I think it was a incredibly thorough, but also very practical and clear overview. And I think a key takeaway for the people who are not as knowledgeable as myself is learning that integrating hormonal management and targeted nutrition and physical therapy can really have a good impact on well-being when dealing with this condition. And we have a bit of space for questions indeed. Eddie here in the audience has her hand raised, so please, Eddie, the floor is yours.
Amanda, thank you so much for your lovely presentation. So informative and so understandable and digestible. And since we are touching also with the Sensopad project upon the diagnostic gap, I would like to draw a little bit from your experience as a clinician. Very often working with patients who have endometriosis. So in your experience during the years, seeing and treating patients with endometriosis, what are the biggest, let's say, symptoms or misconceptions or referral pathways that tend to slow down timely diagnosis? In your experience, why is it that so many women start having a pain through their early menses at 13, 14 years old, and it's not until they're well into their 30s that they're not diagnosed or need to go through I don't remember what the average number of doctor is, but it's a very well-documented path from referral to referral to referral that stretches on for years. So touching on your experience, are there any, let's say, patterns or symptoms that that tend to make cases particularly difficult to detect?
That is a lovely question. And it is a great one, because I think what makes it hard to diagnose is that you could fit it in other questionable categories. So the abdominal cramping, often, if a clinician's not well versed in looking at the other symptoms that a woman may experience, they'll umbrella it as like an irritable bowel or like a gut issue. But I don't feel like that's even looked at down the road either. I think so. It is a women only disease, and overall in reproductive health, we just know less about women and how to treat women. So previously in the past, a lot of studies and whatnot about health were on men. So I feel that has a big to do with why it's difficult when women are talking about having symptoms to know, like, what is this that's going on. I think the other difficult part is a woman will start experiencing it quite young, but irregular periods and discomfort are quite normal when you're 14, 15, 16. So it's easy to then box into the like, oh, that will get better, that should go away. And this is where I think both the Sensopad system that's detecting blood, and then what they're now talking about with testing the blood for anti-Müllerian hormone, I hope, because they're talking about testing women on that before the age of 18, if they're starting to talk about these symptoms, to help be like, they may have endometriosis or PCOS, which is a whole nother thing. I won't even get into it. But I do think largely, though, it is a women-only disease. Women are more complex hormonally, and we just don't know so much about it. And I think now is like the time for women's sexual health, women's reproductive health. Like, we're talking about it so much more. So I think that it could be easily masked for things that bowel related, normal going through reproduction related, that you kind of get boxed in rather than really exploring the multiple symptoms that women can have. And also it could be confused with something like a nerve pain, or they'll just be like, go to pelvic floor physical therapy, you have tightness for whatever reason, but totally miss that the pelvic floor pain is being caused by the endo.
Thank you so much for the response. That's really helpful. Paul, I'm not sure if we have time for one more question.
I think we have time for one more question if Amanda has time for it. Thank you.
Great. Another thing that I know that you work very closely with is patients who've had this for so long that they've developed chronic pain patterns. So what is the role of, how does endometriosis, let's say, intersect with chronic pain, and what is the role of the nervous system in sustaining those chronic pain patterns even after excision surgery in some cases? And why is it so important that, as you mentioned, if you could expand a little bit of that, why is interdisciplinary management so important? Why do we need to work with either a pain management specialist or a therapist specializing in the central nervous system? So what happens in our bodies and our brains that can actually sustain the chronic pain even beyond excision surgery? And you know, is there a way out of chronic pain? I mean, there is, as you clearly showed us, the successful case with your patient before, but I guess it can be it can vary, let's say, from case to case.
Yes, you ask terrific questions. Terrific questions. So, oh gosh. Well, okay, I always explain this one little thing on how our body works, and then I feel like it kind of encompasses why this happens and heightens the longer it goes undiagnosed. So originally, regardless of whether we're male or female, the same initial thing happens when we get hurt or when there's something wrong in our body. So we get all these white blood cells and we get these mast cells, and they come in and they cause inflammation, and that's great because that alarms the body like, hey, something's wrong, let's address this. So that initial inflammation is great. That's why we heal, that's why we get better. The problem is when that doesn't go away. So in the case of endometriosis, just because the mast cells are like, hey, I feel like there's inflammation, I'm going to come in and clear this out, doesn't make the endometriosis lesions go away. They're like, okay. And so now you have this where our white blood cells are supposed to do their job and leave within a few days. They go away and we heal. We kind of build new tissue, whatever might have happened. With chronic inflammation, so we just have these endometriotic lesions staying there, our level of inflammation also stays. The body recognizes that there's something wrong. So now you get this influx of what I call white blood cells and mast cells. All that means is now the nervous system is so hypersensitive. So it is constantly on guard for things that may offset it. So somebody who goes and eats French fries is probably going to be fine that night. They're going to go to sleep, they're going to wake up, and they're not going to think about it. Unfortunately, when there's this like chronic inflammatory state, anything, even slight that comes in, these are the women who are like, oh my goodness, they typically get skin to like easily rashed or like break out, just because their nervous system is so used to constantly fighting inflammation that won't go away. So when you see that constant inflammatory state, muscles over time are trying to protect because the body's sort of in this overdrive of like, what should I do? And so it tightens. And when it tightens, we also have nerves that are protected in our muscles. And we want our nerves to be protected so that if we cut ourselves, we're not impairing nerve function. The problem being, though, if muscles are chronically tight, now you're squeezing nerves. And nerve pain, in its true essence, I find to be one of the most stubborn things to go away. So in the patient case that I just mentioned, she did not have so much pelvic floor nerve pain. So I felt like she progressed relatively well. When there's some significant nerve irritation or inflammation, then I do find the trajectory is longer. And that's when you want to outreach. So sometimes holistically with nerve pain, it's not enough to downregulate however many years. And that's when I find something stronger to break that upregulatory cycle. So that's your Botox, that's your neuromodulating medication. So that's sort of the Lyrica, Cymbalta, gabapentin fields. It sometimes is the most aggressive way, in a good sense, to target what's been going on for years and years and years. And I think that's the importance of when you're talking about the interdisciplinary team, is knowing like, are they going to get better through these more natural conservative treatments, or do we have to start experimenting with something a bit less conservative to break that cycle?
Thank you so much for answering this. Yeah, extremely interesting
Absolutely.
and informative, for so many people out there who are struggling.
Yeah, I always say, like, be your best advocate. It's not the fault of the doctor you're seeing if they're just not accustomed to it, but look for someone else. Like, I think we all have good gut intuition and we know when something isn't quite right. And I would say go to someone else, get a second, a third, a fourth opinion until somebody actually listens to what you're experiencing. Pain is never normal. I think that's a good takeaway.
Thank you. Thank you so much.
Thank you.
Yes, thanks a lot for these insights as well. I think with this, our webinar is coming to an end. So I want to say thank you again. Big thank you to all our presenters today for taking the time to share your expertise with us. Also, I want to say thank you to whoever's out there watching this recording. Thank you for your attention to this as well. If you have specific questions for Dr. Stuart, you saw her email in her slides, so you can reach her out there at info@amandastuartphysicaltherapy.com. And also for Sensopad, the work continues, as was shown in the timeline before, and you can find more information about our progress at sensopad.eu and also in our social media channels. So with this, thank you all for tuning in, and we hope that this webinar has provided you with valuable knowledge and empowered you to pursue comprehensive care. So have a wonderful day, and thank you again. Bye-bye.
Thank you.
Thank you very much.
Thank you.